Hello, welcome to another session of Digital Surgical Pathology, Slide Review and Sign Out. I'm Dr. Lewis Hassel, coming to you from the University of Oklahoma Health Sciences Center, part of OU Health. Our program today is centered on some of the treatment responses that we sometimes see with various background treatments and how those can be confused sometimes with actual disease that may be a greater concern. So our patient is a 44-year-old woman who's had a recent diagnosis of cervical adenocarcinoma, stage 1B1, and has undergone surgical therapy, followed by some fairly intensive radiotherapy involving vaginal cuff brachytherapy. So she comes back for her follow-up visit following completion of that treatment a few months later. And as is typical, the clinical exam, a little bit difficult, but there's some dryness and some redness in her vagina that creates some concern. So in thinking about this, I think it's important to understand the concepts of treatment of cervical carcinoma. Of course, early stage disease, minimally invasive or surface disease is handled pretty much exclusively with cone biopsy or excision. Cryotherapy not particularly totally effective in managing this situation. If the disease is still at a very early stage without significant invasion, a simple hysterectomy may be the course of preference. But once it becomes more significantly invasive, greater than 1 millimeter or 2, then you begin to be concerned about possible spread. And so radical hysterectomy with or without sentinel lymph node biopsy may follow. And depending on final staging, additional adjuvant treatment may include vaginal cuff brachytherapy with or without chemotherapy, and whole pelvic radiation with or without chemotherapy, depending on the nodal status and extent of disease. In truly advanced cases, occasionally to salvage circumstances, anterior exoneration may be a feasible option, but that is used fairly infrequently at this stage in time. So what is the risk of recurrence? I think that's a very interesting question to answer. So this study by Turnhoff, looking at over 1,500 women from Denmark who had stage 1A1 or 1B1 cervical cancer. They found in their registry 80 patients who had developed a recurrence at some point during follow-up. Interestingly, 10% of those recurrences were in patients with stage 1A1 disease, fairly limited stage disease. Obviously, squamous carcinoma more frequently encountered and thus more frequently represented in the recurrences. And of note that a fair number had been found to be lymph node negative. And this underscores the purpose and value of adjuvant radiotherapy in preventing these kinds of recurrences. Not surprisingly, depth of invasion was significantly correlated with the proportion of recurrences. And likewise, the severity of the vascular or lymphatic invasion similarly predicted higher risk of recurrence. Well, so let's think about our patient here. There was not a mass lesion noted. There was just some abnormal appearance to the mucosa. And the patient had reported some degree of discomfort. So as we look here, we see a stratified squamous epithelium. There is, some loose basket weave type of appearance. There's not a lot of hypercellularity here. But as we begin to look at these cells, we notice that, lo and behold, there are a lot of atypical features to this squamous epithelium, particularly at the base. We see some pleomorphism to the nuclei, some mitotic activity, some hyperchromasia, and some of this begins to come upward into the stratified squamous epithelium. And this was true in each of the fragments. We could look at this next one over here. and see that, yes, the same finding is found. And there's a little bit of disarray to this epithelium. Well, this certainly is not cancer, but in the setting of potentially an older patient and what we've recently learned about differentiated VIN and so forth, one might begin to wonder, is this sort of a differentiated type of change associated with this? And certainly if you didn't have the history and you were just approaching this case as a de novo situation, biopsy of a patient with vaginal irritation or something, you might be very concerned about this. Well, we had some concerns, and so one of the things that we did was to do a P53 stain. And then things become interesting because look at this. This is the pattern that I've told you in other videos is what we see with differentiated VIN. A tremendous positivity along the basal squamous layer in virtually every cell, highly dense, intense staining in all of those nuclei. And this was present in each one of these fragments that was removed. So does this indeed represent a differentiated vaginal intraepithelial neoplasia? In other words, a non-HPV related pre-neoplastic event? Is she harboring another cancer after having been treated for cervical cancer? Well, I didn't want to think so. And so we looked at things that might help us. One, we did a GATA3. And GATA3 was not lost in these cells. It was still present, which was a good sign. And we also did a Ki67 stain to see if there was any significant increase or pronouncement in these basal cells. And while there is some positive staining here, we notice that it's strictly along the basal keratinocytes. There's no upward migration. And it's certainly not every cell. It's not a uniform, highly prevalent finding in this situation. So given that circumstance, we were reassured. But I think it raises the question of, what are some of the early complications of radiation therapy? And these can be somewhat different depending on whether it was a very localized high-dose brachytherapy or whether it was a whole pelvic radiation therapy, because obviously the intensity of the abnormality here is going to be vaginal, whereas this may involve the bladder, the bowel, the rectum, bone marrow, skin, et cetera, et cetera. With brachytherapy, you're almost exclusively dealing with local irritation, inflammatory changes, some swelling or soreness. And then the later changes would be some degree of fibrosis, bleeding, vascular abnormalities, and so forth. With whole pelvic, again, you can get more serious fibrosis and stenosis in the vagina as well, along with dryness and so forth. But you can also see late complications in the bones, such as avascular necrosis or stress fractures or other osteopenias, along with various cytopenias that can develop as well. So this brings us to reemphasize the point that P53 expression does not always mean neoplasia. TP53 expression in the pattern that we've indicated is not specific for a generalized mutation, but may be an induced response, up-regulating, if you will, in response to a variety of stresses. And as we know, UV damage, radiation damage, replication stresses can and have to go through TP53, and therefore that may be upregulated to govern the response in terms of whether apoptosis, autophagy, or various other changes are going to occur. So it's helpful to understand the molecular biologic pathways that are operating under various circumstances and the markers that we're using to indicate or take a sense of those pathways as we operate here. So our final sign-out diagnosis is radiation-induced vaginal squamous atypia, a reactive phenomenon without evidence, clear evidence of neoplasia. Well, thanks so much for joining me. I hope that that will provide a little bit of insight to you in how I approach various therapy-related issues. And we hope that if you like that, you'll share that with your colleagues. Be aware for these sorts of changes in your own practice. And we hope also that you'll hit that subscribe button. And until next time, thank you so much for joining us.